The will to win, the desire to succeed, the urge to reach your full potential. These are the keys to unlock the door to personal excellence. Good evening, everyone. Hope you all are doing well and staying safe at home. Today we have Dr. Sanjay Miglani with us. Dr. Sanjay Miglani is a pioneer in endodontics and working as a professor at Jamia Millia University, Delhi. He is a Secretary General of Indian Endodontic Society. He is also immediate past president of Asian Pacific Endodontic Confederation. He is a director, Indian Board of Endodontics, and he is also a visiting honorable visiting professor, School of Dentistry, Tehran University of Medical Sciences. He has contributed several years of excellence in this field. Today, Dr. Sanjay Miglani will enlighten us with tips and tricks of composite restoration in pediatric dentistry. This topic is one of an important component of clinical practice within a pediatric dentistry. I wish this webinar will be useful to all of you. Over to Dr. Sanjay, please.
Thank you, Gyaninder. At the outset, I would like to thank Dr. Gyaninder and other office bearers of SAAPD for inviting me to give this talk. This topic was given to me by Gyaninder because he felt this is the need of hour, and there are so much to learn from the newer materials which are coming every day. Thank you, Gyaninder. I hope you are staying home and staying safe. Gyaninder and me go back for almost 15 years. I'm losing hair and he's gaining more hair every day. I don't know how, but thank you for the opportunity. And next 40-45 minutes, I'll discuss a bit about composites and how it can change our clinical practice and how you can improve your practice with little bit of tips which can be incorporated in your existing practice, because I know you all are seasoned practitioners, and most of you are doing composites in your pediatric patients. And thank you for bringing this beautiful smile on the children. To be frank, I don't treat children. I'm a restorative dentist basically. My wife is a pediatric dentist, and she brings smiles on these faces. And next 45 minutes we will have a small discussion, and after that I'll be open to questions, if any. So in dentistry, if you see, especially in restorative dentistry, our challenges today are, I'm not talking about COVID challenges, but otherwise the patients are much more aware of what they were a few years back, or maybe a couple of decades back. We call them Google generation. And when they come to your practice, they actually come up with the diagnosis and the treatment plan and about the newer materials. So you have to be really aware of what is happening new in dentistry today, and especially for the material, because there's a big boom of material in the market. So you have to see, understand, and incorporate them in your practice. With this, you also have to make sure that your treatment is cost effective, not only to you, but also to your patients. And please do understand that these newer materials are quite technique sensitive. So you cannot just buy a new material and use it like the older one, because it is important to read the manufacturer's instructions if you want the newer material to succeed in your practice. And please also understand that there is nothing permanent but the change. So you have to be ready to change in terms of your practice, in terms of your materials, and in terms of your knowledge. And it is important to update it regularly. I always give a tribute to these two people. Because of them, we restorative dentists are what we are today. G.B. Black, who introduced amalgam to us, and Michael Bunocore, because he was the one who introduced adhesive dentistry to us. Any material which you use in for restoration actually is an artificial replacement, and it has to be compatible with tooth and investing structures biologically and mechanically, irrespective of which material you are using. So when a patient is there in your dental chair, and you need to decide which restoration has to be given. So there are multiple factors in your mind that which path do I take? The general dilemma in your mind is whether I should go with the existing resistance and retention, or should go for preservation. On one hand, you have amalgam, which is serving us for almost 100 years, and it is like a wife. It gets old with time, but always remains faithful. There is no forgiving material than this in dentistry even today. But the irony is, this is the material used most practically, but this is also a material which is abused verbally the most. And you must have heard this goodbye amalgam. Even I feel, in many of the cases, it is time to say goodbye amalgam, although not all the cases. Am I against amalgam? Absolutely no. I use amalgam in my practice for many of the cases where I feel I'm not able to, achieve isolation in toto. And in those cases, I prefer to use amalgam than using a composite. But the reason is something else, and absolutely it is not because of mercury. I think this is only a commercial made up that amalgam causes mercury toxicity. The reason is this: if I have a clinical case, and just imagine that I have these 5 small caries spot and I have to restore them. If I am planning to use amalgam, this is what I'll make: a class 1 cavity, which will look just like this. But please understand that every restoration has an age, maybe 10 years or 15 years. So if you have done this for a 15-year-old child for a first permanent molar, by the time he turns 60, he will have 4 to 5 cycles of changing this restoration. And can you imagine that every time he changes or we remove the restoration, put another one, we also tend to remove some extra amount of tooth structure. So by the time he'll become 60, I don't know how much amount of tooth structure will be left. Whereas if you think about composites, they offer something which amalgam does not offer to us. If I have composite with me, I can just excavate caries from those areas which are carious and then put composite restoration. And thereby, I reduce the amount of sound tooth structure which I'll be removing. So just imagine, even after 5 cycles or after 50 years, I will not be removing that much amount of tooth structure which I may have removed by making a normal class 1 cavity. Along with this, the composite also help us to have a restoration which can be retained in non-retentive preparation because they bond with the tooth structure, whereas the amalgam does not bond to the tooth structure. And of course, it has an aesthetic appearance, and with modern generation, everybody wants to have a restoration which looks like a natural tooth or mimic the natural tooth structure. And other advantages, it also reinforces the remaining tooth structure because it is bonding to the all parts of the cavity. The other major advantage of this composite restoration is that you have the opportunity to repair and refurbish the restorations when they leak, whereas you may not have the same. Just a second. Yeah, sorry. If you have amalgam restoration which has a micro leakage or it has broken from somewhere, you need to remove the whole restoration. Whereas when you have composite, you do not need, you just can repair and refurbish the restoration from that area. So thereby again preventing the excessive loss of tooth structure. When we are doing composites, as a pediatric dentist, you may have these doubts in your mind. Whether it is good for pediatric patient or whether the steps are different adults or the longevity. Many of the clinician complaints of post-operative sensitivity and also discoloration of the restoration. I was browsing through the literature and I came through this guidelines of American Academy of Pediatric Dentistry, and they have clearly recommended in their guidelines on pediatric restorative dentistry that enamel and dentine bond strength for both primary and permanent teeth are same, and if you use manufacturer's instructions, it is equally effective in primary and permanent teeth in terms of restoration, minimizing micro leakage or reducing sensitivity. So what they basically wanted to say that the success rate of or the longevity of composite restoration or the way you do it in permanent and primary dentition is all the same. and he has indicated composites for almost class 1 to class 5. You can use it if you are able to achieve the isolation. However, they have had some contraindications that if the tooth cannot be isolated, the composite should not be used. Or where there are large multiple surface restoration in posterior primary teeth, they recommend use of some sort of a crown like stainless steel crown. Or in patients where you feel who exhibit poor oral hygiene and the compliance to daily hygiene is unlikely or the maintenance is unlikely, it is better not to go for composite restorations. So key points, for when you differentiate between primary and permanent teeth, I think the key points are for us, not for the pedodontists, because we all know that primary teeth have thinner enamel and dentine than permanent teeth. The pulp chamber is of course larger. The interproximal contact is broader and flatter in permanent teeth. I think this is the only difference in terms of preparation, in terms of restoration between permanent and primary teeth. And if we think about the longevity of composites, the studies have shown that large composite restorations have almost equal longevity compared to amalgam, and provided that patient, operator, and material factors are taken into account when restorations are performed. So, if you understand the material, if you have taken the basic principles you have kept in your mind, the composites will stay actually longer than the amalgam restorations. So welcome to the world of adhesive dentistry. The issue of discoloration and polymerization shrinkage, I'll be discussing with you in the later part of the lecture. The ABC of adhesive dentistry is acid etching, bonding, and composites. So I'll talk about it in a brief, and then if I have some key points in between, I'll keep on giving it to you. So acid etching, we know it is simple. We use nowadays generally 37% phosphoric acid, and that gives us the best definition of pattern. And 15 to 60 seconds of etch time is actually sufficient, and it gives us a similar amount of roughness. And what does etching do? In enamel, it increases the porous area from 1 to 13.4%, and where the monomers can flow. In dentine, you have intertubular dentine, and what happens is intertubular tubular spaces open up, whereas when you talk about peritubular dentine, the dentine tubules open up and also the surface energy decreases. But the key point in enamel etching or dentine etching is, if after etching the patient has spat, or if he has rinsed his mouth, or the tooth has come in contact with saliva or sulfurous fluid, you will not have effective bonding, because hydroxyapatite as well as dentine has the power to absorb the proteins very efficiently, and they cannot be removed by rinsing alone. So it is very important that in case the etched enamel or dentine is contaminated, you must re-etch the surface again. And coming to bonding agent, I think all of us, if I ask you what are the types of bonding agents, and we come up with generations, and I think the bonding agent generations have become like an iPhone. Every year you will have a new generation. So it is time actually to forget about the generations, because by the time another 10 years you will have 20 generations of bonding agent. But as of today, for easy understanding, you can divide them basically in 4 types. You have multi-bottle total etch, where you had a etchant, a primer, and bonding agent. The one bottle total etch, where you had a conditioner, a primer, and a bonding agent. And a mixed self etch, where you had 2 bottles which you had to mix. And today the latest generation is one-step self etch. But why is it so important? I'll discuss with you later. So if you think about bonding with enamel and dentine, then enamel bonding is very easy, because enamel is a hydrophobic structure, and whereas dentine is a hydrophilic structure, and the bonding with dentine is much more difficult and much more lesser stronger compared to enamel. The reason is because you have multiple structures in dentine, like dentine tubules, you have odontoblastic process, you have intertubular dentine, and they all contain fluid. And this fluid actually is makes it a hydrophobic structure, and that's why bonding is difficult with dentine compared to enamel. The second problem comes when you etch and you dry. You can dry the enamel, that's not a problem. But when you dry the dentine, you may over dry or you may under dry. Many of the researchers have said you leave the dentine surface moist. Some of them say you leave it wet. You see, some of them say you leave it dry. So with my naked eye, I actually cannot make how wet is wet. So it is difficult. If you have over dried, your restoration will have poor survival. If you have left it over wet, your restoration will have lesser survival. So how do we tackle that? See, most of the newer bonding agents, which are self-etch, are water-based and not based on ethanol or acetone. So this single-step bonding agent, self-etch bonding agent, gives us a lot of advantages, where you have no mixing or rinsing of the tooth, so you don't have to dry it. And it actually gives you less post-operative sensitivity, because it is not removing the smear layer, but it is penetrating the smear layer and incorporating it in the hybrid layer. So the dentine tubules are blocked or clubbed, and this works in moist and dry environments, and you can have light cure or dual cure. Only disadvantage is it has to be refrigerated, and the shelf life is little lesser. When we come to composites, the composites basically are made up of resin matrix, which will have a monomer, which is the lifeline of a composite. You will have initiators, inhibitors, pigments, inorganic fillers to give it strength and reduce the amount of polymerization shrinkage, and you have a coupling agent, organocyllenes, to keep them bonded together. And the monomer, it can be TEC-DMA, UDMA, BIS-GMA, AUDMA, anything, they will shrink. And this shrinkage leads to marginal gap formation. So what happens when you polymerize a resin, with the help of a curing light, it will lead to production of free radicals, which will lead to propagation of polymer chains. So hundreds of monomer units will join with each other, and we expect 50 to 60% of conversion of these monomers into polymers, and that's how the termination of polymerization happens. So this is how polymerization happens. So to make it simple, I made a small video today afternoon with my family to tell you how polymerization happens actually. I made this small video, and as I have been told by my wife that the voice was not audible. However, I'll explain you. If you have different monomers, and when they join hands and make a polymer, they have to come near to each other, and that is what is polymerization. And polymerization leads to polymerization shrinkage. So I'll explain to you in the next few slides. Before that, you also need to understand the classification of composite resins. Initially, we had traditional composites, microfilled, small particles, and hybrid. Microfilled were used for anterior teeth, and hybrids were used for posterior. And many of the practitioners, the elder practitioners, will remember that we needed to keep a big inventory, because we needed separate composites for anteriors and separate composites for posteriors. But with the advent of nano hybrids, it reduced, and Now we have most of the composites which are available in market are nano-filled, and they offer the aesthetic of a microfill so that you can use it in anterior, and the strength of a hybrid for use in the posterior region. So the inventory requirement for a clinic has really reduced after the introduction of these nano-filled composites. When you come to clinical consideration, there's one question which always is there in mind of many practitioners. Do we need a base protection, base for protection of dentine and pulp for composite restoration? My take on that is absolutely not. And this no is not based on my personal perception, but based on the studies which have been done. Studies have shown that if a composite resin which has an effective marginal seal is not dependent on any underlying base to protect the pulp from damaging adverse effect of bacteria, and a polymerized resin does not have any adverse effect on pulp, and you need not be separated from pulp by a base. However, many of the practitioners use it not as a base, but to reduce the amount of composite so that polymerization shrinkage is less, or which is called as a sandwich technique also. But I know many of the practitioners still use glass ionomer cement. Please note, glass ionomer cement is not recommended. The reason is the glass ionomer set by acid-base reaction, which takes 24 hours to complete. And you do not wait for that. You just wait for the initial setting, and then once you etch it and rinse it, it will crumble below the composite restoration, and the restoration will fail. The generally available flowable composites should not be used because they have very less filler content and they tend to shrink. If you take my advice, you can use a resin modified glass ionomer or a light cure glass ionomers, or if you want to use flowable, it has to be a higher film or fiber reinforced flowable composite. When you place a composite in a cavity, you have to balance multiple things. First thing is the basic principle that composite resin is absolutely not a tooth colored silver amalgam material, and it should not be handled in the same way. Especially in a posterior tooth, many people try to condense a composite into the cavity. Please note that composite resin should only be adapted, sculpted to the and shaped to the internal features of the cavity. And it should never be bulk placed. You need to have you need to place it increment by increment, whether you are using it in anterior or in posterior teeth. And please also see if you have seen whether the completed restoration can withstand the occlusal loading. Shade selection is another important point, because I've seen many of the clinicians using Viva shade guide in their practice, and they use it for composites also. Please note that those shade guides are actually made for ceramics, and if you wish to use a shade guide, either you can buy from your manufacturer from whom you have bought your composites, or you have digital shade selectors, which are expensive ones. If you have money, you can buy that. But the easiest way is to you take a couple of desired shade, put it on that tooth or the next tooth, cure it, and you will know which is merging well with the tooth. And to achieve a desired shade, I do not recommend mixing different shades of composites. When you try and mix, what happens? The air is getting air voids are there in the mix, and when you cure it, you will have air bubbles in your restoration, which might crumble with the time, and the restoration may fail. If you talk about isolation, absolutely, composites can never stand moisture, so it is important to isolate. Rubber dam, however, is not always necessary. Pre-COVID, post-COVID, I think it will become a standard protocol. But in my opinion, when you are doing composite, it is the quality of isolation that matters more than the technique which is used to achieve it. So the most common problem with composites is post-operative sensitivity. Now, why does this post-operative sensitivity happens? It does not happen because we are etching a tooth, okay, because that is what people used to think earlier, but it is not that the reason basically is the polymerization shrinkage and not the etching of dentine. Any resin will shrink, as I have shown you in the last video also. And you also have to keep in mind the C factor. The C factor is the bound surfaces by unbound surfaces. So if you see a class 1 has actually higher C factor compared to a class 4 cavity. So clinical relevance of this is, I am again showing a video. My voice in that video may not be available, but then I'll explain you along with this. So if you can't hear it, just imagine that I am the composite and you have a buccal wall and a lingual wall. When curing happens, the composite will bond with the buccal wall and the lingual wall. And as the polymerization shrinkage starts, the composites will start to shrink. When you shrink, the composites shrink, multiple things can happen. You can either leave a wall or you can break this hand and take it along with me, or maybe she can break my hand and take it along with her. So these are the possibilities you have to. So when you do a bulk composites, multiple things can happen. So I will tell you how to manage these problems. So this is what I was trying to explain, that when you put composite, especially in bulk inside a cavity like this, and you try and cure it, the composite shrink. So what happens? It can lead to cuspal fractures, it can lead to enamel fractures, or in a other far case scenario, you can also, if the polymerization stress exceeds the bond strength, you can have these white line margins because composites will leave some amount of the wall. So how do you manage that? There are multiple ways to manage this polymerization shrinkage, and in my personal opinion, the only clinical technique is using an incremental layer and oblique layering technique. So what is the incremental technique? If you have just imagine that this is a class 1 and you have done your bonding. Now you're going to restore it with composite. So you put 2 millimeter layer of composite in oblique fashion. Now just imagine what is happening because of this oblique layering. Now with the oblique layering, first thing is I am putting 2 millimeter layer so that I have sufficient amount of curing. And by oblique layering, I am reducing my C factor. If this was a single increment like this, I will have 1, 2, and 3 bonded surfaces and only 1 unbonded surface. Whereas, so my C factor goes higher and the longevity of my restoration goes down. Whereas if I put it in oblique layer, now I have 1 and 2, only 2 bonded surfaces and 2 unbonded surfaces. So my C factor has half, and the longevity of my restoration will have much more chances. So this is how it happens. I didn't have access to many clinical cases because I have no access to my office, but I had some cases from my last presentation. Please make sure that you keep your inventory ready when you start. This is a case of a central incisor class 4 cavity, and this is how it looked after the restoration. Another lady with failed composites in central and lateral incisors, and this is how post-operatively it looks. This is my patient. Is is senior IAS officer. He came to me for this midline diastema, but in certain social sectors of our society, this midline diastema and central incisors is considered lucky that it brings in money. So he told me to close it a bit, but not totally. This is another patient of mine. I go as an examiner to Kenya. So the internal examiner there had a niece studying in Delhi, and she also had same issues that she doesn't want to close it totally, and we closed it a bit and she was quite happy with it. This is another case of central incisors fracture, incisor ledge, and after composite restoration, this is how it looked. Another case of midline diastema, we closed it totally because the patient wanted it. This is a case of old amalgam which needed to be replaced, and it was replaced with the help of composites. This is another case of central incisor, lower central incisors, which was uh, replaced with composite, the lost part. I have multiple clinical videos which I can share with you on email if you wish. I will give you my email ID at the end. But these were the 7-8 clinical cases which I had available with me right now. So there are a few key learning points you have to keep it in mind when you are doing a clinical practice. That first thing is, you know, composite materials are sticky in nature, and if your instrument adheres to composite resin, it can lead to lifting or displacing them during application, which can lead to voids or marginal defects which can be incorporated in the restoration, and that will lead to a void that whenever there are heavy occlusal forces, they may just crumble, and the void, because of void, the restoration may break. So always use a good quality instrument, and I've seen this practice by some journal and older practitioners. They tend to dip their instruments in either bonding agent, alcohol, or water after every increment. Please, you don't need to do that. An increment should not be more than 2 millimeters in thickness. And when you have darker shades, they actually cure lesser than the lighter shades. So you can either consider increasing the curing time or reducing the amount of thickness of composite which is placed inside the cavity. Keep the activating light as near to the material as possible. And what happens when things go wrong? You know, when you have a newer composite and you try it in your clinic and it doesn't work well, we always blame that company or that composite. But please understand that it is the composites come to market with a lot of R&D, and clinician has to understand the material, understand the conditions they have to use, and in what patients have they used it. So we should confess that what possibly could go wrong with the restoration you are doing in a patient. The common post treatment problems are post-operative sensitivity, restoration failure, loss of retention, discoloration, and loss of marginal integrity. So I will tell you why it happens. The persistent post-operative sensitivity happens because of leakage, stressing or flexing of cusp, or enamel cracking. This is happening because you have not taken into account when you are working on patient about the polymerization shrinkage. If you follow the steps to reduce the polymerization shrinkage, you will not have this problem. That can also happen because of over etching of dentine or over drying of dentine, or maybe retention of etchant. But if you are using a newer generation single step self etch bonding agent, I think this problem will not be there. Please make sure that your light curing unit is checked regularly, and also check for inappropriate occlusal contact. If you take care of these points, the chances of post-operative sensitivity are negligible. The restoration can fracture. So as you see in the last slide also, the problem in the post-operative sensitivity is not a problem of the composite, but the technique and how we use them. Same way for the restoration fracture, if you have left a inappropriate occlusal contact in the restoration, or you have failed to check for any existing parafunctional loading, or patient has bitten on a hard food, it can lead to restoration fracture. Or if you use incomplete polymerization, where you have used thick increments or your light curing unit was poor, that can lead to restoration fracture. Or if there was a presence of a large void, or you have used a cement base like glass ionomer, this can also lead to restoration fracture. So again, most of the reasons here are dentist based and the patient based, and not material based. The loss of retention can happen if you have failed to etch enamel and dentine appropriately, or you have failed to apply the bonding agent appropriately. Contamination of etched and bonded surfaces, as I told you, can lead to the failure of adhesion of composite and tooth structure. If you have inadequately polymerized the composite material, that can also lead to loss of retention. And please always check if there are any inappropriate occlusal contacts left in the restoration. The discoloration can happen because of bulk restoration, where you can have a white line surfaces where because of polymerization shrinkage, or if you have failed to polish the surface properly. It can also happen because of dietary and habitual causes. Always use water when you are polishing your composite, because that can lead to burning of composites actually. The loss of marginal integrity happens because of inappropriate placement technique, inappropriate curing technique, and failure to bevel the occlusal cavus surface margins in anterior. So as I was telling you, if you see the reason of failures or reasons of most of the complications, it is basically in our hands and not in material. So the moral of the story is the best hands to help are your own hands. You will not have a hand of God and when you are practicing, and because it is important to know that the patient will complain to you that the filling did not last. He will not pay any heed that the material was inferior or you didn't know how to use the material. They will only blame you. So it is important to understand the material and use them as per manufacturer's instructions. So that I will give you some take-home messages so that they may help you in having a restoration which has a longer longevity and make your life easier. Please understand, all composites will shrink. So placement technique is more important than the choice of material. In market today, there are a lot of bulk composites. You can use them because they have different scientific techniques of reducing the shrinkage by using longer monomers, or some of them use photo-initiating inhibitors. You can use them, but don't think that they don't shrink. They also shrink, but maybe a little lesser. Many of us has a habit of keeping our composite kits inside the refrigerator, especially in warm weather like this. And when the composites are cold, they actually cure less effectively. So it should be kept at room temperature at least 1 hour prior to the use. Nowadays, we also recommend pre-warming of composite because that can increase the conversion of monomers into polymers. Use a light source with sufficient intensity, because with time the composite curing units become old and you will not have sufficient intensity actually to cure your composites. And when you have thicker layer of composites, the curing actually reduces. So you may expect less polymerization or less polymer conversion in the deeper layer of composites. That can again lead to failure of restoration. The ideal distance between light source and composite is 1 millimeter at 90 degrees from composite surface, and if you keep it far, the composite might not cure at all. As I have again and again told, the increment should not be 1 to 2 millimeter, because that gives the optimum polymerization of composite resins. If you have thicker layers, the composite at the deeper layers may not cure well. Darker shades, you should use them. They cure slowly and less deeply compared to lighter shades. And so if you're using darker shades, you can use either lesser amount of composites, or you can cure them for longer time. This is another very important thing. As soon as the composite restoration is over, we start polishing them. Please understand, when you have given the last shot of curing light, the curing light time is over, but the polymerization is still happening inside. It needs to reach its final threshold before you start polishing it. So it is always recommended, once you are finished with your composite restoration, ask the patient to sit for 10 to 15 minutes before you start polishing them. If you start polishing your composite immediately, you have not allowed it to complete its polymerization totally, and thereby reducing the strength of composite, or thereby reducing the total longevity of the composite restoration. So I always recommend waiting for 10 to 15 minutes. Please also note that your operatory light can also cure composite. So it is important because it has visible light as well as UV light and infrared light. This can also cure composite, but bad curing will happen. So I personally advise you can either use an orange filter over the operatory light, or just keep it at least at double distance. It gives you sufficient time to work on the patient, and the curing does not happen. Also, the number of cycles of curing on a particular tooth will depend on what is the size of your curing light. You know, many of us have a tendency that we just put it on tooth because the light is spread everywhere. We give a one cycle. Please note, if the size of the restoration is bigger than your curing light, you may need to give multiple cycles for it to cure. This is another area of concern, that many of the times when we etch a tooth, especially in anterior, we etch the areas which may not be part of your restoration. So that area has become demineralized, and when it is subjected to coffee, tea, or tobacco, they will stain. So you will have a restoration which is well polished, but the area around it may be stained. So if you have done that, I would recommend that before sending the patient, do a fluoride gel application in that area before you send the patient home. This is one more important thing. You know, many of us have our own practice, and what happens, we buy a composite kit which will have 6 syringes and 1 bottle of bonding agent, and before the syringes, the bottle of bonding agent may get over. So many of us have a tendency to go to market and buy a bonding agent which is the cheaper one or cheapest one, maybe from a good company. But if you want a stronger bond between the bonding agent and the composite, it is important that they both are made from same chemical, because some companies use TECDMA, UDMA, some may use BIS-DMA. So those two different chemicals may not bond that strongly with each other. So it is very important that when you replace your composite resin syringe or your bonding agent from your kit, they should be from similar company. So please understand that the key to success does not depend on the restorative material, but it is dependent on you, how you do it, because at the end of the day, you are answerable to the patient. So I wish you all the success. I hope you could get some clinical points about composites, and I thank all of you for listening to me. I would like to personally thank Dr. Gyanendra for inviting me to speak here, and I know 45 minutes is the optimum time when you have sufficient attention. I also have a 3-hour presentation on this. Maybe some particular day I may invite you to Jamia and join our session. These are my details, my beautiful family. If you have any doubts, you are more than happy to contact me. You can call me also. The only condition is my wife should not be around. Rest all is fine. Thank you very much. I'm more than happy. If there are any questions, I'll be happy to answer them.
Dr. Miglani, thank you for a wonderful presentation. You gave us some tips and tricks of the composite resins, which generally used in pediatric dentistry. There are some relevant questions, just I will just take up.
Absolutely.
Dr. Rita Poptani and Dr. Abhishek Pujari are asking, what is the ideal time of etching? Is it the same for permanent or temporary?
Yes, absolutely. For permanent and primary teeth, I prefer to use only 15 seconds. Although if the tooth is fluoride, in case of patients who have fluorosis, you can go for a higher time, but otherwise 15 seconds is sufficient to etch.
Okay. Dr. Bishesh Singh is asking, sir, what why can't mix with the two composite of same brand just to get a desired shade?
Hmm.
She's
Pardon?
asking, why can't we mix the two composite of same brand to get a desired shade?
See, this is a very common question, and I will not recommend because most of the times what we do, we take out composites from two syringes and mix them on a glass slab. This will incorporate air bubbles in between the two composites, and most of the cases you will find that there are voids in the final restoration, and they may break with time.
And Dr. Anu Roy is asking, while repairing the composite, we don't remove the entire composite, but using the
Yes.
composite from the different company or brand will have the same bonding strength compared to previous restored composite resin.
See, a stored composite with same company will definitely have better bond strength, but sometimes the patient has come from a different clinic and you really don't know that which company composite they have used. So it really, it is better to repair the composite instead of removing the whole thing. It might have lesser bond strength, but it will survive.
That's uh, that's all the questions. Thank you, Dr. Sanjay Miglani, for a wonderful
Thank you
presentation,
so much.
and
Thank you so
thank
much,
you one and
Ganendra.
all. Yeah, thank you one and all for being with us during this time and being a wonderful audience. I wish you must have utilized these webinars for the best of your potential, and these webinars should leave some impact on all of us. I want to thank all our esteemed speakers who gave their valuable time and guided us generously. We have decided to pause webinar for a while. Soon we will be back with a great speaker. Once again, I wish all you the luck. I wish I wish you all the luck and a healthy life by staying at home. Thank you. Stay safe and stay healthy. Thank you, Dr. Sanjay.
Thank you, Ganendra. Can I leave the meeting?
Yeah, yeah, sure.
Thank you so much, brother.